I think the stream is live. Very good afternoon to all of you who are watching it live. And those of you who are going to catch it up later also, a very good, whatever time of the day you are watching it, good evening, good morning, right? So we have a very esteemed guest with us today. We have Dr. Vineet Goel, and this is the first of its kind session that we are doing in the series called Think Like a Topper, for especially meant for NEET SS aspirants. So what is Think Like a Topper? Why are we even trying to do this? See, the primary thing we believe is that knowing concepts is one thing, solving a Q bank is one thing, but attempting a GT and especially holding your nerves on the D day is a completely different ball game. Because when you practice typically a Q bank, you may be practicing some particular topic of cardiology, or you may be practicing some particular topic of nephrology. So you know that all the questions that are going to come in front of you are going to be in that particular order. But when it is a GT, it's a mix of all kinds of questions. And how do you identify what to prioritize? That, I think, is best heard when it comes from the horse's mouth. We have with us Dr. Vineet Goel, who has secured All India Rank 4 in NEET SS 2023. All of the people who are actively preparing for NEET SS 2024, which unfortunately is not happening in 2024, this is going to be very helpful to draw key insights and look into the brain, look into the mindset of a topper to understand कि यार करना कैसे है, on what basis do I eliminate options, on what basis do I clinically on what basis do I analyze a clinically oriented question, on what basis do I eliminate options in a fact based questions, on what basis do I leave a question, on what basis do I take guesses. That is what primarily we want that is what primarily Dr. Vineet will be taking you through. So a brief introduction about Dr. Vineet. As I already told you, he has secured All India Rank 4 in NEET SS DM 2023. He has completed his PG from Lady Hardinge Medical College, and he is currently doing his DM cardiology from one of the most esteemed hospitals in the country, from Safdarjung College, from Safdarjung Hospital in Delhi. So Dr. Vineet, I welcome you, and the stage is all yours.
Thank you so much, Ravi.
And thank you so much, Dr. Vineet, to find time for us, for taking for guiding the students who are going to follow your footsteps. Thank you so much for taking time from your hectic schedule. Dr. Vineet, you may go ahead and share your screen and take the students through your insights.
Oh. Hello everyone, I'm Dr. Vineet Goel, currently pursuing my DM cardiology from Safdarjung Hospital. I'm going to take a GT from DocTutorial. So it will be just an approach, how to approach the MCQ, and not about testing me, as I've not touched Harrison since past 1 year. So please don't judge me. This is a disclaimer. So I'm going to solve the GT4, which was released on 10th of August in DocTutorial. So these are the instructions. Please read the instructions very carefully. And the main thing is the question you attempted and marked for review will be considered for evaluation. And there is another option, that is question mark for review, that will not be considered in evaluation. So read the instructions carefully. And I will be starting the test. So which of the following produces pansystolic murmur? So this is pretty easy question, but these type of question can also be tricky sometimes. So read all the options carefully, as the D option is all of the above. Do not directly jump into option A, mitral regurgitation. So probably option D will be the answer. 4-year-old lady. So this is the long question. So first, for the long question, the clutch is first read the last line. What is the question is asked? What the question maker is asking? Based on the patient's presentation, laboratory finding, imaging result, which combination of hormone replacement therapy and therapeutic intervention is most appropriate? So 34-year-old lady, endocrinology clinic with a 6 month history of fatigue, weight gain, cold intolerance. So T4 is low, TSH is low, and prolactin is high. So we will treat for hyperprolactinemia and for hypothyroidism, which is primary hypothyroidism, mainly originating from pituitary. And ACTH is normal, IgG1 is normal, and patient also has mild bitemporal hemianopsia. So it is most likely pituitary adenoma compressing the optic chiasma also. So we need to do transsphenoidal surgery also. So we will give levothyroxine, and for hyperprolactinemia, dopamine agonist, and transsphenoidal surgery. The most likely answer is A. So if you are getting confused in these type of question, you can always mark for review, and later on you can review these type of questions. 45-year-old patient is brought to the emergency department with sudden onset fever, rapid heart rate, high blood pressure, and excessive sweating. Recent history of brain and spinal cord injury. So it is asking what is the most likely diagnosis. On examination, patient appears agitated and pupillary dilatation is noted. Revealed tachypnea and flushing of the skin. There is no history of hypertension and heart disease. So we will so these type of questions, we will rule out the options in these type of questions. So in neurogenic pulmonary edema, as there is no history of pulmonary distress, respiratory distress, this option is ruled out. And in malignant hyperthermia, we can keep this as a diagnosis, as a differential. Autonomic storm. So there is history of brain and spinal cord injury, and history of increased sympathetic drive. So we can consider this as an answer. Serotonin syndrome, there is no history of any drug intake, so this can also be ruled out. Malignant hyperthermia, also there is history of drug intake, so we can mark autonomic storm in this question. 40-year-old male, which of the following is most likely the offending drug? Seizure disorder, complain of pain epigastrium, continuous radiating to back and fever. Serum amylase lipase are raised. So we all know valproate causes, the side effect of valproate is acute pancreatitis. So we can mark valproate. Presence of which of the following in a comatose patient indicates bilateral pontine damage? So these types of questions are important. The pontine damage, pontine hemorrhage, what are the clinical signs? So ocular bobbing, we usually see in bilateral pontine damage, we usually see the fast downward movement with slow upward movement. This is ocular bobbing. Match the lymphomas: maltoma, peripheral T cell lymphoma, angioimmunoblastic T cell lymphoma, and mantle cell lymphoma. So I know that angioimmunoblastic T cell lymphoma is trisomy 3, and I don't know about peripheral T cell lymphoma, not otherwise specified, and mantle cell lymphoma is 11-14. So 4 is A. So in other option, we have to rule out if you don't know all the translocations, but few, you can always read all the option and mark whether you are matching or not correctly. 4 is A in only B, option B. So we can mark this option. Which of the following classification criteria? So this is from rheumatology. It is asking about classification criteria. Young male comes with asymmetric polyarthritis and ray pattern in X-ray. Ray pattern is seen in psoriasis, and the classification criteria for psoriasis is Casper criteria. So this is a long question. I will read the last line first. What is the diagnosis of the patient? So 45-year-old male, gradually enlarging abdominal distension, fatigue and weakness, massive ascites, splenomegaly, testicular swelling. USG abdomen, USG showed fatty liver, massive splenomegaly, bowel thickening, mesenteric lymphadenopathy and testicular mass, probably a lymphoma or something. Hemoglobin is 7, TLC 2300, platelet is 70,000. Peripheral smear shows pancytopenia with normal RBC morphology. Bone marrow aspirate, monotonous, medium-sized cells with round nuclei, basophilic cytoplasm with vacuoles. So this bone marrow aspirate is, I think, I don't remember exactly, but I think it's Burkitt lymphoma. pathology feature is suggestive of Burkitt lymphoma. So you don't have to read all the you don't have to read, know all the clinical manifestation. Some clues you have to pick from the question also, like in this question, bone marrow aspirate is showing medium sized round nuclei with basophilic cytoplasm with vacuoles. This is a typical feature of Burkitt lymphoma. And immunophenotyping, if you remember, well and good, and if you don't, then look for the other clues also, and you can always leave the question, as you don't have to make all the 50 questions correct or mark for review if you want to take a guess and take a risk. Which of the following is the most likely diagnosis? So this question is also asking for the diagnosis. 12-year-old patient, recurrent episode of muscle weakness, proximal sparing bulbar muscles, are often triggered by rest following exercise, and during these serum potassium level are slightly elevated. So, hyperkalemic may show reduced motor amplitude in hyperkalemic muscles. So, this is in genetic testing as SCN4A gene. So, this is this a question is giving us many clues that high potassium levels are high, periodic paralysis. So, answer is hyperkalemic periodic paralysis. Which of the following statement regarding relative incidence of severe complication of falciparum malaria is false? So this is fact-based question. Convulsions are very infrequent in pregnant women. Hypoglycemia is very frequent in children. Pulmonary edema is infrequent in children. Renal failure is infrequent in children. So these type of question you can always leave if you don't know, if you don't have any clue. Better not to attempt these kind of questions. So either mark for review if you have any idea, or if you want to give some time to this question, but I will leave this question. In the above scenario, what is the appropriate recommendation of treatment? So question is about chronic hepatitis B, 40-year-old male, present with abdominal pain, weight loss with decreased appetite. Baseline investigation along with viral load were done, which were as follows. Hemoglobin 11, TLC 4500, bilirubin 1.2, ALT 50, HBV DNA 5000, HBAG status is negative. Although HBAG negative, but HBV DNA is more than 2000. So this is the criteria to treat the drug. Although and bilirubin is low, and there is no ascites or signs of decompensation of chronic hepatitis B. So it is a compensated chronic liver disease. So we will treat it with oral agent. We have to treat this patient as HBV DNA is high. There is no indication of liver transplantation, and PEG interferon is not indicated in this, and no treatment and monitor only. No, we have to treat this patient as HBV DNA is high. Question is about Sydenham chorea. All of the following are true, except read the questions carefully, as except is there. Sydenham chorea commonly occurs in the absence of other manifestations. True, because it is a late manifestation of rheumatic fever. Coriform movement affect particularly the head. True, and the lower limbs. No, it affect the upper limb. And again, read all the options. Often associated with emotional lability and OCD. Yeah. Medication to control the abnormal movement do not alter the duration or outcome of chorea. Yeah, true. So answer is B. So again, it is asking about diagnosis. Which of the following is most likely diagnosis? A young male suffered snake bite 10 days ago. Local swelling that has managed with debridement. Anti-snake venom was administered. He was discharged after 3 days of hospitalization with partial recovery of his swelling. Now he's complaining of new onset myalgia, arthralgia, and fatigue for 1 day he has developed. Examination show wound is healthy, but there is cervical lymphadenopathy. Which of the following is most likely? So option A is intermediate syndrome. Intermediate syndrome is associated with organophosphate poisoning. So this option is already ruled out. Secondary infection of the wound, as wound is healthy, as mentioned in the question. So this option is also ruled out. Serum sickness to anti-snake venom. This can be the answer. And critical illness myopathy. No, there is no history of any prolonged hospitalization or ICU admission. So this is also ruled out. So option C, I might think, will be the answer. First line therapy for systemic mastocytosis with c-KIT mutation. This is also a fact based question. So if you know it, well and good, and if you don't know it, do not touch this question, these type of questions. So I will leave this question. Which of the following is not a paraneoplastic syndrome reported in carcinoma lung? Again, fact based question. So acanthosis nigricans, I know. Dermatomyositis, I know. This is the paraneoplastic syndrome. Non-bacterial thrombotic endocarditis, it can be or it cannot be. So I'm confused between two options here, A and D. So I will mark for review these type of question and will give time later on if time remains. So next question is what increase in stroke volume should be there to consider it as volume response? A 21-year-old male presents to emergency department on recording vitals. His vitals were MAP was below 65. You being posted in emergency department, try to assess volume responsiveness to stroke. So increase in 12% of stroke volume is considered volume responsive. Again, these type of questions are fact based. If you know, you know, and if you don't know, do not touch these type of questions. Which of the following biomarker are used for diagnosis of systemic mastocytosis? Tryptase is used. So yeah, I'll mark tryptase. Again, fact based question. In these type of question, do not confuse, as there is all of the above. This all of the above is just given to confuse you. So in diagnostic criteria there is only serum tryptase level. So you can take an guess in this question. You have to take risk in these type of question. If you know diagnostic criteria contains tryptase and not chymase and serine protease, so you can mark tryptase. If some question will get wrong, but you have to take guesses also. Based on the clinical presentation and additional symptom, what is the most likely diagnosis? 55-year-old male, recurrent episode of severe paroxysmal pain on one side of throat near the tonsillar fossa, intense, triggered by swallowing or coughing. The pain radiates from throat to the ear. Reports no motor and sensory deficit and has experienced bradycardia, hypotension, fainting, and frequent episode of sudden loss of taste sensation on the posterior third of the tongue. Medical therapy with carbamazepine has been initiated, but the patient seeks further evaluation based on clinical presentation and additional symptoms. What is the most likely diagnosis? But trigeminal neuralgia clinical feature doesn't fit in trigeminal neuralgia. There is no facial pain. There is throat pain. Glossopharyngeal neuralgia, yes, we can consider. Vagal nerve compression, I don't know. Nerve compression could cause these type of symptoms. Bell's palsy, it is out. So again, in this type of question, I am confused between B and C. So I can mark for review and will see this question later on. Which of the following mechanism is not correct with respect to hyperglycemia predisposing to mucor infection? Hyperglycation of iron sequestration protein, upregulation of GRP72, downregulation of COAT-H, defective phagocytosis, upregulation of mucor acid. I have no idea about this question, so I will leave this question. Again, a long question asking about which of the following statement regarding this patient condition, genetic condition, is incorrect. A 5-year-old girl is referred to the endocrinology clinic for evaluation of severe obesity and developmental delay. He has excessive hungerness since infancy, frequent feeding to avoid irritability. The patient is severely obese, pale skin, and red hair. PM genetic testing reveals homozygous mutation in the POMC gene. What is incorrect? Patient severe obesity is due to hyper. Again, I have no idea about this question. I will leave this question. Eosinophil mediated tissue damage is the hallmark of which condition? Eosinophilia associated with the PDGFRA, chronic eosinophilia not otherwise specified, lymphocyte variant hypereosinophilia, hypereosinophilia. Again, if you know the fact, if you know about all this condition, you will be able to mark the answer. But I will leave this question. Which of the following genetic abnormalities is the most commonly associated with other? Again, a fact-based question, but ADPKD is an important topic. You cannot leave this topic before NEET SS. You have to revise some important topics. So ADPKD is one of them. So most commonly gene associated with the ADPKD is polycystin 1. I will mark this answer. Which of the following statement is not true? Bile acid. Do not waste much time in this question. If you know, you know. If you don't know, leave this question and go ahead. Which of the following statement is not true? Bile acid diarrhea has reduced ileal bile acid absorption. Fatty acid diarrhea has reduced ileal bile acid absorption. Bile acid diarrhea does not respond to cholestyramine, and fatty acid diarrhea does respond to cholestyramine. Uh, Fatty acid diarrhea does not respond to cholestyramine, and bile acid diarrhea does respond to cholestyramine. I think there is some mistake in this question. Both are correct. So if this happens in NEET SS, you will get grace marks. And I think fatty acid diarrhea does respond to cholestyramine. Bile acid diarrhea does not respond to cholestyramine. Okay. So I'll mark C or D. C. I will mark C. Board index used in COPD. Components of board index are all except. So board index stand for B for BMI, O for obstruction, D for dyspnea, E for exercise performance. So FEV1 is not a component of board index. If this lady has third pregnancy, what will be your advice for her? So a young female, 2 spontaneous abortions, 6 weeks, present to you for evaluation. There is no history of any vascular episode. High titer of anti-cardiolipin antibody, twice, 20 weeks apart. So it is a case of APLA. Lupus anticoagulant is negative. B2GP1, glycoprotein 1 is negative. The rest of the immunological workup is negative. So if she gets pregnant, we have to start her on prophylactic low molecular weight heparin and aspirin. We give therapeutic, as much as I remember. Therapeutic low molecular weight heparin is given if there is any vascular complication. So there is no history of any vascular episode. So I think I can take an guess in this in this question. Which statement is false regarding voriconazole side effect? Skin cancer surveillance, fluorosis associated peristaltitis, dosage to be reduced in renal failure, visual disturbance. I don't remember actually, but if you know, you know. If you don't know, you go ahead. All of the following are true about prismental angina, except. So this is the question from cardiology, and I've read cardiology very well. You will also read one of the super specialty from because you will also prepare for INA, so that also help you. Cardiology part, the super specialization part which you prepare for is very important, because you cannot leave those questions. So this is question regarding prismental angina. Prismental angina is caused by focal spasm of epicardial coronary artery. True. It may be related to hypercontractility of coronary smooth muscle due to adrenergic vasoconstriction, leukotriene, serotonin. True. Minority of patient has generalized vasospastic disorder with migraine. It is associated with migraine and Raynaud's phenomenon. Nitrate and aspirin are main therapeutic. No, calcium channel blockers are main therapeutic, and aspirin we usually avoid because it inhibits prostaglandin and it may precipitate prismental angina. A patient is admitted in CCU, not tolerating oral feed and relative history of poor glycemic control. Which of the following false regarding nutrition management in medical ICU? Enteral feeding is preferred over parental nutrition. True. If parental feeding is necessary to supplement enteral nutrition, it can be delayed for 7 days. True. Target glucose level is 80 to 120 in critically ill patient. Permissive underfeeding of non-protein calories not inferior to full goal control. So there is the target glucose level is not strict in critically ill patient. It usually we say less than 180 or 200, as much as I remember, but it's not 80 to 180, it's 120 strictly. So I'll mark C, because if patient goes in hypoglycemia, it is more detrimental to the patient. Which of the following autoimmune disease result from failure of generation of T-Rex cell? So T-Rex cell mutation is usually seen in IPEX syndrome. T-Rex and is in autoimmune polyendocrinopathy candidiasis. A.I.R gene is usually seen. I don't know about Hirata disease. I'll mark IPEX syndrome. Fact-based question. False about non-specific interstitial pneumonitis. So, diffuse subpleural symmetrical ground glass reticular opacity are common. True. Commonly observed in patient with CTD. Yeah, true. It is frequently seen in males with history of chronic smoking. Uh, I have remembered that feature of NICP as it is more common in CTD, and CTD is usually seen in female, and female are usually non-smoker. So I have remembered this, remembered the feature of NSIP like this. So I can mark it to C and treat it with oral steroid cytotoxic agent. This is true. As per WHO classification, GI neuroendocrine tumor, which of the following is grade 3? I have no idea about this question, so I will leave this question. Which of the following statement regarding lipodystrophy in HIV is false? Lipodystrophy changes usually occurred after 6 weeks of starting ART. This changes occur with protease therapy. This is true. This changes occur with usage of thymidine analog. This is also true. I'm not sure about option A, so I will mark for review and will review this question later. Is not considered a protein misfolding disorder. Amyloidosis is a protein misfolding disorder. Huntington also. Inclusion body myositis is also. CADASIL is not a protein misfolding disorder. 45-year-old male present with fatigue, weakness, and hypotension. She has a history of breast cancer with chemotherapy and radiation therapy. Laboratory test reveal low cortisol and serum sodium is also low. What is the most likely cause of her symptoms? Primary adrenal insufficiency, secondary adrenal insufficiency due to hypopituitarism, SIDH, hyperthyroidism. So I'm very weak in endocrinology. So either I can mark for review or because I don't want to waste more time in this question. So I'll mark for review and we'll review it later. A relapse follicular lymphoma with EZH2 mutation. Positivity. I don't know. I have no idea about this question. Patient was admitted in medicine ICU, is on improving trend after 3 days of stay. You think of liberating the patient from ventilator support. Which of the following is not a parameter for considering failure of spontaneous breathing trial? Okay. So these kind of question you face day to day in your day to day practice when you are doing your ICU duty. So around 5% of questions you encounter in NEET SS will be from what you experienced during your ICU posting or clinical postings. So respiratory rate more than 30, heart rate more than 140, SBP more than 180, and the patient look anxious and start sweating. Yeah, we have to stop SBT when patient look anxious and start sweating. SBP when reach more than 80 and heart rate more than 140. Respiratory rate is more than 35. You have to stop SBT. So this I think will be the correct answer. Which of the following hormone class is correctly matched with an example? Steroid hormones, large proteins, small neuropeptides, amino acid derivatives. So A is correct. I think amino acid derivatives. I will leave this question. The word metabolomics refers to study of small molecular with molecular mass. A and B options are same. So you can mark either of them. You will get grace marks. So this MRI film is directly from Harrison, showing spinocerebellar ataxia type 1. But again, you have to read the question carefully. So question is asking, based on clinical presentation, MRI finding and genetic consideration, what is the most likely autosomal dominant neurodegenerative disorder for this patient caused by expansion of CAG repeat and ataxin 1 gene mutation? So you can directly mark this SCA1. You don't have to waste time and read whole of the question. Time is also important because you have to complete 1/5 rest of the questions, and you have to go back again for to see the questions you have marked for review. Which of the following DMARD is considered safest DMARD in pregnancy is sulfasalazine? Again, fact-based question. All of the following are true regarding RV systolic pressure as less than 50, except, so this is the question directly from Harrison table. Showing differences between cardiac tamponade, constrictive pericarditis, effusive constrictive pericarditis, restrictive cardiomyopathy. So RVSP is not less than 15 restrictive cardiomyopathy, and rest of the options it is less than 50. Which of the following falls about treatment of vitamin E deficiency? Vitamin E in high doses may protect against RPF and bronchopulmonary dysplasia. Symptomatic vitamin E deficiency should be treated with 800 to 1200 alpha tocopherol a day. Vitamin E has no role in non-cirrhotic, non-diabetic patients with NASH. Vitamin E may increase all-cause mortality and prostate cancer risk. So, a correct answer is E because it has a role in non-cirrhotic, non-diabetic, though it has no role in diabetic patient with NASH. Which of the following has the least chance of developing pulmonary renal syndrome? Goodpasture syndrome causes pulmonary renal syndrome. Cryoglobulinemia causes pulmonary renal syndrome. ANCA-associated vasculitis also causes pulmonary renal syndrome. Fabry disease causes nephrotic syndrome, not pulmonary renal syndrome. Which of the following is true regarding entamoeba histolytica infection? Eosinophilia is prominent in invasive entamoebiasis. Entamoeba hartmanni and Entamoeba coli have more incidence for hepatic invasion. Enta-ELISA is both sensitive and specific. Entamoeba nana doesn't cause clinical disease. So I will leave this question. Wrong about hemothorax. 66-year-old male patient with history of low-grade fever, dull aching pain in right side of chest since 1 month. 6 kg of weight loss. He's a chronic smoker. Chest X-ray revealed massive right side pleural effusion. ICD insertion was done, showing fluid of red color. If hematocrit is more than one half of that in peripheral blood, the patient is considered to have hemothorax. Correct. Most common cause of hemothorax is tumor. No, most common cause of hemothorax is trauma. Hemothorax should be treated with tube thoracostomy, which allows continuation quantification of bleeding. If the pleural hemorrhage exceeds 200 ml per hour, angiographic coil embolization, thoracoscopy, or thoracotomy is required. So I don't remember about option D, but in day-to-day practice, you also see that most common cause you encounter for hemothorax is trauma only, not tumor. So I'll mark this question. This is an educated, experience-based guess. So you have to also see if you don't know the other options, but you can take a guess in these kind of questions. Based on clinical presentation and history, what is the most likely diagnosis for the patient? 52-year-old male with long history of alcohol abuse, complain of weakness and numbness in his extremities, stocking, glove, distribution of these sensory and motor symptoms. He mentioned experiencing difficulty in achieving and maintaining an erection, reduced sensation of light touch, pinprick in symmetric stocking glove pattern, decreased deep tendon reflexes. Patient is orthostatic hypotension. It is usually due to brainstem involvement rather than injury to the peripheral nervous system. Based on clinical presentation and history, what is the most likely diagnosis? So, diabetic neuropathy, as there is no history of diabetes, this option is ruled out. GBS, Guillain-Barré, this is not a clinical picture of Guillain-Barré. Alcohol neuropathy, we can consider as there is history of alcohol abuse, long history of alcohol abuse, and weaknesses like that only. Sensory and motor deficits like that only, stocking gloving. Idiopathic small fiber polyneuropathy, I don't know about how it present, but I can take a guess in this. Alcoholic neuropathy might be the answer. So you have to take the guess in these kind of questions. Peripheral initial management of the patient. A young female with low-grade fever, inflammatory polyarthritis for the last 6 months, no history of skin rash or oral ulceration. For last 15 days, feeling generalized weakness. Evaluation shows ANA positivity, histone 2 positivity. Hemoglobin is 4.8. Retic count is high. LDH is also high. So probably a hemolytic picture. So considering ANA positivity, young female patient is a case of SLE, and SLE is usually associated with autoimmune hemolytic anemia. Treatment, first line treatment for autoimmune hemolytic anemia is prednisolone, 1 milligram per kg body weight. Which of the following is incorrect regarding stress ulcer prophylaxis? In stress ulcer prophylaxis, you usually use proton pump inhibitors. Prophylaxis against stress ulcer is not necessary for all ICU patients. It is correct. PPI and H2 blockers are equally effective. It may increase chances of pneumonia. Stress ulcer prophylaxis does not increase risk of Clostridium difficile. PPI increases the risk of Clostridium difficile. So can be a correct answer. I'm confused in all other, but I'm 70% sure that this is the right answer. So I will take a guess in it. Which of the following terms best describes the type of pain experienced by this patient? 45-year-old patient with history of diabetes mellitus with severe pain in lower extremities. Pain is described as burning sensation, often triggered by even a lightest touch. There is sensory deficit that correspond to the painful area. Patient display exaggerated pain response to mild stimuli. Electric shock like sensation in the affected region. So it is a neuropathic kind of pain, not an inflammatory pain, nociceptive pain, visceral pain. Which of the following hormone measurements is least commonly used in current practice? I have no clue about this question, so I will leave this question. Which of the following false about short bowel syndrome? Uh, False. A patient, the adaptive process generally continues up to 2 years post resection, but improvement in nutrition, fluid, electrolyte absorption may take up to 3 to 5 years. Resection more than 100 centimeter result in severe bile acid malabsorption that the liver cannot compensate for, thus precipitating fat malabsorption. This is true. The frequency of calcium oxalate stone is decreased with the resection of small bowel with intact colon continuity. Calcium oxalate stone risk increases because there is calcium gets saponified with the fatty acid, so it will lead to more absorption of oxalate and oxaluria and leading to increased calcium oxalate stone. So this is false statement. Patient with tuberous sclerosis is found to have renal angiomyolipoma. Is currently asymptomatic at present. At what size angiomyolipoma should be surgically removed? If you know this, this is a fact-based question. If you know the answer, well and good. If you don't know, go ahead. So answer is 4 centimeter, probably, as much as I remember. Sepsis with hyperinfection can be seen in with which hyperinfection is usually seen in strongyloids. Again, fact-based question. Pneumocystis pneumonia prophylaxis should be considered for those patients with of asthma containing maintain on daily prednisolone dose of. So you can take a guess in this kind of question, as there is no physiological dose of prednisolone is usually 5 to 10. More than physiological dose, you have to give pneumocystis prophylaxis. So lowest dose mentioned in this question is 20 milligram. So I will take a guess and mark more than 20 milligram per day in this question. Based on these clinical features, identify what is the most likely autosomal dominant disorder, it is asking. So 25-year-old male with the distal leg weakness noticeable in the form of foot drop, second decade of life. The individual does not complain of numbness and tingling, distinguishes the condition from acquired neuropathy where sensory symptoms usually predominate. Physical examination reveals reduced sensation to all modalities. Muscle stretch reflexes are unobtainable or reduced throughout. There is evident muscle atrophy below the knee, especially in the anterior compartment. Inverted champagne bottle legs, duplication of PMP22. So you have to just learn about one liner in this. CMT is an important topic for NEET SS. So PMP22 gene duplication is usually seen in CMT1A. PMP22 gene is also important in which condition you see deletion, in which condition you see duplication. So we have to remember all these conditions. Here answer is likely CMT1A. Presence of which of the following antibodies is not considered as a risk factor for development of this manifestation in systemic sclerosis? So, a diagnosed case of systemic sclerosis, duration of 4 years, present with new onset dry cough and exertional dyspnea. Evaluation of restrictive PFT. PVC, FBC is 46%, HRCT chest showed an NSIP pattern. So anti-topoisomerase 1 is I don't remember I'm not able to recall actually. So if this is an easy question, if I would have attempted 1 year back, I would have attempted it correctly. But currently, I don't remember exactly which antibody used to be positive in lung involvement. So I will leave this question. What is the recommended target of HbA1c among older adults with intact cognitive function? So target for HbA1c in usually is less than 7, but in older patient with intact cognitive function, this is a direct line from Harrison. It is less than 7.5. Which of the following statement about the prevalence and screening recommendation for common endocrine and metabolic disorder in adult is least accurate? Obesity is defined as BMI of 30 or higher affecting 40% of adults. Screening includes calculating BMI and measuring waist circumference. Type 2 diabetes mellitus. This question is taking much time, and I want to mark for review and will review it later. Which of the following is true about pulse oximetry? Oxyhemoglobin reflect light more effectively than deoxyhemoglobin. Oxyhemoglobin reflect light less effectively. Oxyhemoglobin, this is the basic principle of pulse oximetry. It uses biphasic rays of light at 660 and 990 nanometer. So oxyhemoglobin reflect light more effectively than deoxyhemoglobin. It is also a fact-based question. What is the treatment of choice for intermediate stage multinodular ESCOG 0 stage hepatocellular carcinoma? Question from medical oncology. I will leave this question. 45-year-old patient, which of the following is the most likely diagnosis? 45-year-old patient with the complaint of muscle weakness and exercise intolerance, exhibit ptosis and ophthalmoplegia, asymmetric involvement of extraocular muscle, midfacial neck flexor, proximal limb weakness. CK is mildly elevated. EMG shows myopathic process. Muscle biopsy revealed ragged red fibers. So ragged red fibers are feature of, in this question there is only catch is ragged red fiber, which is feature of mitochondrial myopathy. So answer is mitochondrial myopathy. Which of the following differentiate silicosis from asbestosis except upper lobes are affected in silicosis, pleural thickening and calcification and plaques are feature of asbestosis. In chest X-ray you also see holy leaf sign. So answer is pleural thickening of calcification and plaques. So again read all the options. Increased risk of MTB due to macrophage dysfunction in silicosis, true. Increased risk of RA scleroderma in silicosis, true. All of the following disorder are causes of thrombotic microangiopathy except malignant hypertension, true. Aplar, true. Preeclampsia is also microangiopathy. Membranous nephropathy is the correct answer. In which of the following there is a table in Harrison for this thrombotic microangiopathy? So tables from Harrison are very important because questions directly come from tables from Harrison. In which of the following acute intestinal ischemic condition early laparotomy is indicated for the diagnosis? Non-ischemic mesenteric ischemia, arterial thrombosis, arterial embolism, mesenteric venous thrombosis. I will leave this question and mark for review later. Later on, I can give time to ponder over in this question. Clearance of solute occurs in dialysis by which technique? Diffusion, true. Again, read all the options. Adsorption, no. Convection, true. Both A and C will be the right answer. Maximum contribution to seizure in HIV patient is by HIV encephalopathy, cerebral toxoplasmosis, cryptococcal meningitis, primary CNS lymphoma. So I will leave this question. I'm not able to recall about this question. Which of the following is antagonist to both IL-4 and IL-13? Mepolizumab. Mepolizumab is IL-5. Reslizumab is also IL-5. Omalizumab is Ig receptor auto antibody. Dupilumab is the correct answer. IL-4 and IL-13. Fact-based question. Which of the following antibody is most likely associated with this condition along with accompanying encephalomyelitis and immune response characterized by antibodies and cytotoxicity? Okay. 60-year-old male with asymmetric dysesthesia, sensory loss, progress to affect all limbs, torso and the face. Patient also reports sensory ataxia, pseudoathetosis and inability to walk. Subacute sensory neuropathy is suspected. Further evaluation of paraneoplastic association primarily related to lung cancer. Patient neurological symptoms have predicted the identification of lung cancer by less than or equal to 6 months. Marked sensory ataxia, pseudoathetosis, inability to walk. So catch here is sensory ataxia, which paraneoplastic autoimmune antibody causes sensory ataxia. This is axonal neuronopathy. As much as I remember, it was pattern 5 neuropathy. unresponsive to treatment, glucocorticoid, anti who used to cause the axonal neuronopathy. So you can mark the question. Positive Durkin test is used for carpal tunnel syndrome. You median nerve is pressed in this test. The second test is Fallon test and Tinel test also. Likelihood of positivity tests question from statistic is sensitivity by 1 minus specificity. Do not waste much time in this question. If you know, mark the answer. For which condition is a karyotype recommended as a part of diagnostic workup? Turner syndrome, Klinefelter syndrome, hypogonadism, male, polycystic ovarian syndrome. So, in Turner syndrome, you you recommend diagnostic workup for genetic testing, karyotype recommended. False statement regarding marginal zone lymphoma. Hepatitis C is associated with lymphoma of mucosal associated lymphatic tissue. True. Malt of skin is caused with chronic skin infection with Borrelia abscelli. I have no idea. Hepatitis C infection is associated with splenic marginal zone lymphoma. I have no idea. So I will skip this question. Which of the following statement is true regarding HSV treatment? Ganciclovir is as effective as acyclovir for HSV infection. Complete course of IV acyclovir eradicate the latent herpetic infection in 70% of the patient. Daily acyclovir therapy given for suppression of mucocutaneous herpes is associated with reduction in HIV RNA in the genital mucosa. Infectious medicine is a weak area for me, so I will not give much time in this question. Daily acyclovir therapy given for suppression of mucocutaneous herpes is not associated with reduction in HIV RNA in plasma. I will skip this question. Or maybe I can mark for review and later on read this question very carefully. 65-year-old female present with complaint of swelling of both limbs since 5 months, existential dyspnea since 6 months. Echo showed ejection fraction of 38%. She is diabetic, hypertensive since 15 years. Which of the following beta blocker is least useful in this patient? Patient is a case of HFrEF. So in HFrEF, 3 beta blockers are recommended: bisoprolol, carvedilol, metoprolol. Atenolol is not recommended. Which of the following genetic defect is most likely responsible for this patient autosomal dominant disorder? Ashkenazi's Jews with slowly progressive ptosis, limitation of eye movement, sparing pupillary reaction. Does not complain of diplopia with extraocular muscle impairment. Serum CK level 2 to 3 times. EMG showed myopathic changes in weak muscle. Muscle biopsy showed muscle fiber rim vacuole and electron microscopy revealed 8.5 nanometer tubular filament. Neck and proximal weakness. I have no idea about this question. I will leave it. A middle-aged male, sore throat for last 2 days. She started amoxicillin by himself. 2 days after starting the drug, he developed generalized arrhythmia with high-grade fever. 2 days later, developed innumerable pinpoint pustules over arrhythmia. There is no mucosal involvement. Blood investigation revealed leukocytosis with neutrophilia. Skin biopsy showed collection of neutrophils, sparse necrotic keratinocytes in the upper part of epidermis. What is the most likely diagnosis? Steven-Johnson syndrome, acute generalized exanthematous pustulosis, Dress syndrome, and there is no eosinophilia, so Dress is ruled out. Fixed drug eruption does not present like this. I will mark B, taking a guess in this question, but I don't know if it is correct or not. But you have to play aggressively sometime for a good rank. Which of the following is not considered an absolute contraindication to postmenopausal hormonal therapy, but rather a relative contraindication? I'm not able to recall. Which of the following statement is false regarding the disease? 50-year-old male came with complaint of heartburn, recurrent vomiting since 1 week, which didn't reveal on symptomatic management on antacids and prokinetics. Endoscopy was planned. It showed thickening of rugal folds. Biopsy revealed large cell with vesicular chromatin, prominent nucleoli. Showed positivity of CD19, CD20, BCL2, BCL6, CD10. Bone marrow biopsy was shown. Disorder is a risk factor for the development of this disease. Prolonged antiacid therapy, involvement of adrenal glands such as CNS dissemination. Cure can be achieved in 60% of patients. So I'm not able to recall. I will leave this question. The preferred first line therapy for H. pylori positive and T translocation 1118 negative gastric malt lymphoma. So this is also important. Malt lymphoma and H. pylori are associated. So eradication of H. pylori in if translocation 1118 would have positive, so we should have we should have given involved field radiation therapy also, but in this case we will give eradication of H. pylori therapy only, because marked lymphoma respond very well to H. pylori kit. 50-year-old male patient was to be started on anticoagulation for atrial fibrillation. The bleeding risk is to be assessed for anticoagulation. All of the following components are included in assessment of bleeding risk, except. So we usually use Has-Blood score for assessing the bleeding risk for anticoagulation. Has-Blood stand for hypertension, labile INR, age of more than 65, and altered liver renal function, drugs or alcohol intake. So age is more than 75, not 72. A 50-year-old male who had a history of bleeding, PR, and constipation. Colonoscopy was done, which showed sessile serrated polyp of 8 mm. Histology showed no dysplasia. What is the recommendation for repeat colonoscopy? Uh, this is the fact-based question. If you remember the table from Harrison, which is for screening for colorectal cancer, it is well and good. If you don't remember, you can leave these kind of questions. All of the following are true about HOCM, except exertional intolerance may have chest pain. True. Ejection fraction is usually less than 30%. HOCM is usually cause of heart failure with preserved ejection fraction. Ejection fraction is usually more than 60%. So you can, without looking at other option, you can mark this option. All of the following glomerular image is best described in which of the following? The following glomerular image. So this is direct image from Harrison. If you remember well and good, I'm not able to remember it, but there is mesangial deposit and more mesangial cells, which is usually seen in IgA nephropathy. So I will mark IgA nephropathy, but I'm not sure. I will take a guess. Which of the following is not seen on imaging in chronic eosinophilic pneumonia? Photographic negative of pulmonary edema is seen. Atelectasis and septal thickening, pleural effusion and lymphadenopathy is seen. Subpleural honeycombing is not seen in chronic eosinophilic pneumonia. It is a feature of idiopathic pulmonary fibrosis. Which statement regarding treatment of Chagas disease is false? Treatment duration is of 2 months. No dose adjustment required in kidney disease. In adult chronic cardiomyopathy, benzimidazole has no effect on mortality. True. Benzimidazole is not effective against digestive complication. I will leave this question. Which of the following is most likely autosomal dominant disorder for this patient? 20-year-old patient with recurrent attack of pain, weakness, and sensory loss in the distribution of brachial plexus, often occurring in childhood, triggered by stress or the postpartum period. Patient has dysmorphic feature, hypotelorism, apicanthal fold, cleft palate, syndactyly, micrognathia, and facial asymmetry. Electromyographic demonstrate an axonal process. Genetic testing reveals SEPT9 gene mutation. Which of the following is the most likely autosomal dominant disorder for this patient? So we'll try to rule out the option. Refsum disease, I know Refsum disease usually presents with hyperpigmentation, and they must have mentioned the deformities of foot in this case. So we can rule out. Tangier disease, they must have mentioned the orange tonsils or something. Fabry's disease, there is history of recurrent stroke, and the skin lesions must have mentioned. So these three I can rule out. And hereditary neuralgic myopathy, by the name, if we break the disease name, neuralgic amyotrophy, this is correlating with the clinical presentation they have mentioned. So we can take a guess and mark D in this question. Again, this can be right, this can be wrong, but you have to take risk sometimes. Which of the following drug are not associated with tendon rupture? Quinolones are associated with tendon rupture. Glucocorticoids are also associated with tendon rupture. Statins are also associated with tendon rupture. So none of the above will be the correct answer. Which of the following statement is false regarding control of dengue? Control of yellow fever. Yellow fever is also caused by Aedes mosquito, so this may be correct. Wolbachia infected vectors, I have no idea. Risk of severe dengue decreases in seronegative vaccine patients. I have no idea. None of the above. So I will leave this question. A suspected case of poisoning is admitted in the critical care unit. 2 hours after admission, he had one episode of GTCS. Which of the following drugs should not be used for management of seizure in this patient? So we know that in acute poisoning, we should never use phenytoin. This is a fact-based question. If you remember, well and good. All of the following endocrine disorder result from mutation of in the GS alpha subunit that prevents GTP hydrolysis. I have no idea. I will leave this question. Most potent TKI for CML. So I think it's dasatinib, but I'm not sure. I'm taking a guess in here. What is the current guidelines for colorectal carcinoma screening with no personal or family history of colorectal polyps? Start at 50 years and screening with annual fecal blood occult blood test. Start at 45 years and screening with annual fecal occult blood test. As there is no personal history and no family history, we should I think start at 45 and screening with annual fecal occult blood test coupled with flexible sigmoidoscopy every 5 years and colonoscopy every 10 years. Started for 50 years. I'm sure that it starts with 45 years, but I'm not sure whether we do sigmoidoscopy and colonoscopy also. But we can take a guess in this kind of question, mark for review, and later on we will review this question. 60-year-old hypertensive patient present with acute chest pain, which is tearing and dripping type. Diagnosis is aortic dissection. What is the first line of management? We give beta blocker and vasodilators. So nitroprusside and metoprolol will be the correct answer. Labetalol alone, yeah, we can give labetalol, but not alone. Phentolamine not. Nicardipine and ilabrin no. Which of the following is PRP inhibitor approved for therapy in breast carcinoma? This is fact-based question. I think it's olaparib. Which of the following disease is most commonly associated with AA amyloidosis? Most common cause of AA amyloidosis is rheumatoid arthritis. This is again fact-based question. Gold standard for diagnosis of visceral leishmaniasis. So even if you have not read about this, but these kind of question you can attempt. Gold standard is always biopsy or any test in which you can directly see the organism. ELISA is antigen based. LAMP is no. Tissue aspirate can be a gold standard diagnosis because we can directly see the trophozoite of leishmaniasis in this. So we can take a guess and mark the answer in this kind of question. Which of the following genotype is associated with hypersensitivity to allopurinol? So again, fact-based question, which is 5801. During the Hepatitis Awareness Month, you are asked to enumerate the high-risk population for whom HPV infection screening is recommended as a part of general awareness program. Which of the following is not a part of the list? Person with HCV infection should be screened for HBV. Pregnant women should also screen for HBV. Blood donors should also screen for HBV. But hereditary elliptocytosis, I don't know. But other three should be screened for HBV. We usually do in day-to-day practice also. So we can take a guess and mark hereditary leptocytosis. 55-year-old male presented with complaint of shortness of breath, palpitation, and mean pulmonary arterial pressure is more than 20, suggesting of pulmonary hypertension. Pulmonary arterial wedge pressure is more than 15, suggesting of post-capillary pulmonary hypertension, and PVR is less than 3. So ruling out pre-capillary pulmonary hypertension. So it's a case of isolated post-capillary pulmonary hypertension, which is due to left side heart failure. So answer is group 2, pulmonary hypertension. 17-year-old male presented with fever, lymphadenopathy, splenomegaly since 3 days. Typical rash was as shown in this figure. Laboratory investigations TLC 22,000, greater than 10% atypical lymphocytes with mild transaminitis and elevated bilirubin. Peripheral smear shows this is atypical lymphocytes usually seen in infectious mononucleosis. Which of the following statement is false regarding this condition? Tender symmetrical lymphadenopathy, tonsillar enlargement with overlying exudates, morbilliform rash is more frequently seen in patient treated with penicillin. Such penicillin associated rash are predictive of future risk of adverse reaction to penicillin. Giving penicillin in infectious mononucleosis can cause morbilliform rash, but however, it is not predictive of future risk of adverse reaction of penicillin. So we can mark this. Although I don't know about option A and B, but we can take a guess in this kind of question. Which of the following is correct about maneuvers for testing nerve root disease? A straight leg raise test. SLRT is used for L2, L4 nerve roots and sciatic nerve. Reverse SLR sign is more specific than SLR for diagnosis of disc herniation. Reverse SLR test for L5 S1. I will leave this question. Which of the following treatment strategy involving Vaptan therapy is most appropriate for this patient, but clinical outcomes should be monitored? 65-year-old woman present with confusion, nausea, headache. Laboratory finding reveals serum sodium concentration of 120, plasma osmolarity of 260. She has a history of small cell lung carcinoma, is diagnosed with SIDH. Despite initial fluid restriction, her sodium level remains low. Which of the following treatment strategy involving Vaptan therapy is the most appropriate? Start conivaptan with a loading dose of 20 mg over 30 minutes. So this is regarding the drug therapies. I will leave this question. I am not able to recall. If you have some clue and you want to give this question some time, so you can always mark for review, and later on you can review this question. Molecular relapse in ALL is defined as patient in complete remission, MRD not detectable. Patient in complete hematological remission but not in molecular complete remission. Patient in complete remission had prior complete remission. I will leave this question. Which of the following is false about the non-invasive method of assessing hepatic fibrosis and cirrhosis? A.R.F.I. method, there is a table in Harrison for this non-invasive method for assessing hepatic fibrosis and cirrhosis. This is an important question. A.R.F.I. is a method measures shear wave genetic acoustic radiation force imaging. A.R.F.I. stand for acoustic radiation force imaging. So we can mark this is true. T method is fibroscan, shear wave generated by vibration through liver tissue. This is true. APRI method has AST and platelet count as its parameter. This is true. ELF method has 3 parameters. No, it has 4 parameters. Mnemonic for ELF method is math. So we can mark option D. Which of the following drug may precipitate the symptom of heart failure in this patient? 65-year-old male, diabetes, hypertension since 20 years with complaint of dyspnea and pedal edema 6 months. Echo showed ejection fraction of 40%. Which of the following drugs may precipitate the symptoms of heart failure in this patient? NSAIDs. This is a question regarding precipitation factors for heart failure. NSAIDs precipitate heart failure. Calcium channel blockers also precipitate heart failure. Inadequate use of diuretics also precipitate heart failure. So answer is all of the above. Which of the following organism is most likely? 11-year-old child brought with complaint of headache, vomiting, neck rigidity, ptosis with enlarged pupil. TLC is high. CSF is grossly purulent. Gram stain culture were negative. Patient father recalls that they had gone to a trip and were indulged in recreational water support. Acanthamoeba, Belmitia, Meningococcus naegleria. So this probably a case of PAM, primary amoebic meningoencephalopathy. So because there is history of recreational water support, so Naegleria pylori may be the answer. You have to look for the clues. Like in this question, there is given recreational water sport activity. So this indicates Naegleria pylori meningoencephalopathy. A 60-year-old patient with neurological symptom, including suboccipital pain, spreading to the neck and shoulder. Clinical examination revealed weakness of the limbs. Imaging study indicates lesion near the foramen magnum. Which one of the following patterns of limb weakness is most likely to be observed in this patient? So probably a case of foramen magnum syndrome. In this, we usually see Ellsberg phenomena is given in Harrison only, which is clockwise weakness of muscles involving ipsilateral arm first, then ipsilateral leg, then contralateral leg, and then contralateral arm. So, answer is A only, ipsilateral arm first. Okay. Which of the following is most likely industrial toxin? It's a toxicology question from toxicology. Industrial, we usually skip this topic from Harrison. Industrial worker who is employed in metal plating factory reports to hospital with fatigue and exertional dyspnea for last 3 months. Examination showed yellowing of teeth, moderate anemia, bilateral polyphonic bronchi, evaluation of microcytic hypochromic anemia, and mildly deranged renal parameters. So I don't remember other things, but I remember that yellowing of teeth occurs in cadmium toxicity. So I can mark this. Again, if you don't remember, you can always skip this question. What is false regarding? 27-year-old was admitted with personal diagnosis of pyrexia of unknown origin, hepatomegaly and splenomegaly were there. Routine blood test as shown hemoglobin 8, TLC 6000, platelet 99,000, serum ferritin was 5,000, bilirubin was 2.5, ALT was 250, AST 270, triglyceride 250. So dyslipidemia is there and low fibrinogen level. What is the false regarding this condition? Hepatomegaly, fever of unknown origin, hepatomegaly and splenomegaly with bicytopenia, with the high triglyceride level, suggestive of HLH. It is asking about false condition. EBV is the most frequent trigger. Hematopoietic stem cell therapy is the only curative option. And unremitting activity of CD4 cell, EBV is the most. I'm not able to recall, but I think A with the answer. Hematopoietic stem cell therapy is not the only curative option in this, but I'm taking a educated guess in this question. Which of the following statement regarding pathophysiology and management of adrenomyeloneuropathy is correct? 40-year-old present with symptoms of peripheral neuropathy, including weakness, numbness, and tingling in bilateral lower limb. His clinical evaluation diagnostic worker revealed mild to moderate peripheral neuropathy with laboratory evidence of adrenal insufficiency, typical feature of adrenal leukodystrophy. Pathophysiology and management of AMN is correct. Asking about correct statement regarding AMN. AMN is primarily a demyelinating disorder, and nerve biopsy typically showed demyelination without axonal loss. Diets low in very low chain fatty acid and supplementation with Lorenzo's oil have been consistently shown to be effective in reducing very low chain fatty acid levels and improving neurological symptoms. Adrenal insufficiency is rarely seen in patients with AMN, and hormone replacement therapy is not usually required. AMN is caused by mutation in paroxysmal ABC transporter gene. So this is correct. It is usually seen caused by mutation in ABC transporter gene. Uh, which of the following statement is false? 45-year-old African male came with complaint of irregular fever, neck swelling, posterior lateral aspect on one side, movable and painless, edema of face and extremities, pruritus, circinate rashes on the trunk, nocturnal insomnia and daytime sleepiness. Blood smear showed the following image. So the neck swelling in posterior lateral aspect of one side, suggestive of winter bottom sign, seen in trypanosoma infection. Uh, the myocarditis potential complication with the most patient ending up in congestive heart failure. Symptom of adrenal insufficiency can be present. Symptom of thyroid insufficiency can be present. TFT thyroid function tests are normal. So usually there is silent myocarditis in this kind of patients. So we can mark this answer. Which of the following is not complication of parenteral nutrition? Hyperglycemia is a complication. Hypoglycemia is also a complication. Hypertriglyceridemia can also occur. Intrahepatic cholestasis usually occur, not extrahepatic, and that too rarely. Which of the following is false regarding management of this patient? 50-year-old male present with chest pain, sweating since 1 hour. The pain is radiating to left arm, left upper jaw. ECG showed inferior wall MI. BP was 90/60 and heart rate was 62. Question is asking about false statement. So better to avoid nitrate, true, as BP is in lower side. Patient is should be given initial dose of antiplatelet and anticoagulation. True. Fluid should be avoided in this patient. All of the above are false. Fluid should be given in patient with inferior MI patient because it can be it usually associated with RVMI also. So fluid should not be avoided. Fluid should be given. Which of the following best characterize the gait disorder seen in this patient? 60-year-old male with gait instability, difficulty maintaining balance during locomotion. Patient has a narrow base of support, which rule out cerebral ataxia. Frequently looks down at their feet while walking. Joint position vibration sense also diminished, suggesting of proprioceptive loss. So we can directly mark sensory ataxia in this case. Most common cause of dry tap during bone marrow aspiration is causes of dry tap. These all cause these are all causes of dry tap. So most common cause of dry tap is hairy cell leukemia, I think, but this is just a guess. I don't know. Which of the following is not a stimulator of T-pit? I have no idea about this. I will skip this question. Which of the following is true about poem in achalasia? A tunnel is created in the mucosal layer of esophageal wall. Submucosal. GERD is the side effect of this procedure. True. At 2 years, greater symptom relief seen in pneumatic dilatation. I don't know. Longitudinal muscle of LES and distal muscle are transected. GERD is a side effect of this procedure, and I have no idea about the other options. So I can mark this and I can take a guess. Which of the following is false about treatment of this patient? Billroth procedure a few weeks back, and now patient complain of nausea, diarrhea, palpitation 30 minutes after meals. So this is early dumping syndrome. So treatment for this is small multiple meal. True. Elimination of liquid during meals and minimize carbohydrate intake. Guar and pectin should be taken. Elimination of liquid during meals and minimize carbohydrate intake is also true. Guar and pectin also true. Depot formulation of octreotide once every week. As the other options are true, so we can mark and take a guess on this question also. What is most likely autosomal dominant neurodegenerative disorder caused by unstable CAG repeat with 80XN3 gene mutation? So this is SCA3 gene mutation. You don't have to read the whole of the question if you can make an answer from the last line only. So SCA3, other name is Machado-Joseph disease. Which of the following type of skin lesion show pathergy phenomenon? Pathergy phenomenon is seen in I'm not able to recall. Pathergy phenomenon is the when you inflict a trauma and the lesion develop on the trauma site. This is pathergy phenomena, but I'm not able to recall which of this skin condition causes it. So we'll leave this question. Which of the following test is most likely to diagnose the etiology? 38-year-old mother, of three, presents to the primary care office with complaints of fatigue. She feels that her energy level has been low for the past 3 months. She was previously healthy and taking no medication. She does report that she has gained about 10 pounds and has severe constipation, for which she has been taking a number of laxative. Her TSH was 25, free T4 was low. She's wondering why she is hypothyroidism. What is the most likely etiology? So, three past 3 months. Antithyroglobulin antibody. So we can skip this question. Most likely, the answer is serum thyroglobulin. I don't know. I will skip this question. Which of the following condition is most likely responsible for the infant symptoms? Infant, 9-month-old infant with developmental delay, muscle weakness, and episodes of vomiting. Clinical examination revealed hypotonia, poor head control, delayed motor milestone. Genetic testing confirmed mutation of TK2 gene. Which of the following is the most likely? We can TK2 spine not seen in myotonic dystrophy. And this is not a picture. These clinical picture is not suggestive of myotonic dystrophy, neither DMD. We can take a guess and mark mitochondrial DNA depletion syndrome, but it is just a guess. Which of the following is true regarding ventricular fibrillation and ventricular tachycardia post-MI? So prophylactic lidocaine use can reduce the overall mortality due to STEMI. No, false. Hypokalemia can decrease the risk of torsades de pointes. It increases the risk. False. Prophylactic antiarrhythmic are indicated to prevent VF and VT. No, false. ICD placement is considered in patient for patient who develop VF and VT lately. True. After 48 hours, it is indicated. Which of the following is not a criteria for sphincterotomy? Patient underwent laparoscopic cholecystectomy for gallstones who developed jaundice and right upper quadrant pain 1 week following discharge. And USG was done, which showed no collection of mid-inflammatory changes in RHC. LFT showed abnormal value of ALP. Patient was diagnosed to have SOD. Which of the following is not a criteria for sphincterotomy? So I will leave this question. Patient on hemodialysis comes to you with history of frequent intradialytic hypotension. Which of the following drugs should be considered in this patient? Midodrine can be considered in this patient. Midodrine is considered for hypertension. Which of the following is false regarding infectious mononucleosis? In places with poor hygiene, EBV tends to infect children at lower age. CD4 CD8 ratio become inverted. This is true. Lymphocyte in the crypts of the tonsil are the reservoir for EBV. EBV infects the epithelial cell, then goes into the lymphocyte. CD21 is the receptor for EBV on B cells. So we can, if it is taking time, we can mark for review and go to the next question. 30-year-old male with obesity, intellectual disability, progressive vision loss. Physical examination reveal this polydactyly. He also reports history of renal abnormality. Reveals BBS10 mutation deletion seen in Bardet-Biedl-Moon syndrome. Which of the following additional endocrine abnormality is most commonly seen with it? Hypogonadotropic hypogonadism is seen in BBS syndrome. Which of the following is variable is represented on y-axis in ROC curve? On y-axis there is true positivity rate, and on x-axis there is true negativity rate. Which of the following statement regarding natalizumab and PML is correct? The incidence of PML is highest in first year of natalizumab treatment and decreases thereafter. No, it increases thereafter also. Measurement of antibody against JC virus in the serum is not useful in assessing the risk of PML in natalizumab treated patient. JC antibody negative patients have a minimal risk of developing PML. True. Seronegative MS patients undergoing natalizumab therapy treatment do not need regular monitoring of JC antibody status. No, they require regular monitoring. This is also false. Question is asking about correct answer. The third one is correct. JC antibody negative patients have a minimal risk of developing PML. Which of the following statement is true about amiodarone-induced hepatotoxicity? All patients with elevated aminotransferase level have clinically palpable hepatomegaly and liver disease. Cationic amphiphilic drug and major of its metabolite accumulate in Kupffer cells. A simple microscopy can distinguish between amiodarone and alcohol hepatitis. Pseudo-alcohol liver injury can range from steatosis to alcohol hepatitis or cirrhosis. I'm not able to recall. I will skip this question. Which of the following indicates unstable angina? Sudden onset, usually lasting for more than 30 minutes, often associated with shortness of breath, weakness, nausea, vomiting. No. This is MI. Marked severity of unrelenting pain, usually associated in the setting of hypertension. This characteristic pain is of aortic dissection, typically less than 20 minutes, lower tolerance for exertion, crescendo pattern. This is characteristic for unstable angina. Which of the following statements about the treatment is not true? 45-year-old patient present with the perineal abscess fistulizing Crohn's disease. On admission, vitals were stable. Patient were initially treated with antibiotic and drainage of abscess. However, refractory to the treatment, you decided to start biological treatment with an immunosuppressant. Which of the following statement about the treatment is not true? So the dose of azathioprine ranges from 1 to 1.5, whereas the dose of mercaptopurine ranges from 2 to 3 milligram per kg per day. Pancreatitis is seen in azathioprine and 6 mercaptopurine. This is true. CBC and LFTs should be monitored frequently regardless of dosing therapy. This is also true. Risk of lymphoma, thiopurine associated lymphoma is seen in more than 65 years of age. I have no idea about this question, but catch is azathioprine is azathioprine metabolites into mercaptopurine. So the dose of azathioprine should be higher than mercaptopurine. We can take a guess by this, and we can mark A in this question, because in this the dose that of azathioprine mentioned is lesser than the mercaptopurine, which cannot be possible. Which of the following is incorrect match of drugs with their mechanism of action? Bivaludine's direct thrombin inhibitor is correct. Ticagrelor is reversible platelet P2Y12 inhibitor. It is correct. Cangrelor is irreversible platelet P2Y12 inhibitor. Fondaparinux is synthetic factor 10 inhibitor. Cangrelor is also reversible platelet P2Y12 inhibitor. All of them are pyrogenic cytokine except IL-1 is pyrogenic cytokine. TNF is also pyrogenic cytokine. So I don't know about ciliary neurotropic factor in none, but we can take a guess in this. And if you want to play aggressive, you can choose one option and try your luck. Which of the following is the most appropriate next step in the management of this patient? 6-month history of headache, gradual visual field loss, bitemporal hemianopsia, 2 centimeter cellular mass, suggestive of pituitary adenoma. More than then what is the most appropriate step? So we should go for transphenodal surgery in this patient. More than equal to 2 centimeter is indication. All of the following are true regarding, and also it is compressing the optic chiasma, so we should go for transphenodal surgery. All of the following is true regarding the treatment of this condition. 55-year-old male from South America, present with complaint of pedal edema and exertional dyspnea. History of some infection to the heart and GI system. 15 years back. ECG showed AV nodal dysfunction and right bundle branch block. So clinical picture is suggestive of Chagas disease, as patient is from South America, and history of heart failure with the AV block. All of the following is true regarding the treatment of this condition except ventricular atrial fibrillation, ventricular tachyarrhythmia can be seen. True. Small ventricular aneurysms are common. True. Particularly at the base. No, at the apical aneurysm are common in Chagas disease. Benzimidazole does not prevent disease progression. Serological test for specific IgG antibodies against the trypanosome lacks sufficient specificity and sensitivity. I'm not sure about option D, but I'm sure that option B is incorrect because aneurysm are more common at apex. Consider the following statement. Left side fallopian tubes are more commonly affected in females with Crohn's disease. Infertility due to treatment with sulfasalazine is reversible in males with IBD. Moderate ulcerative colitis or Crohn's disease has no effect on birth outcomes. Vaginal root delivery is preferred over cesarean section in patient with CD. This is true. Patient with quiescent ulcerative colitis and Crohn's disease have normal fertility rates. This is false. So we can skip this question and mark for review, and later on we will review this question. All of the following are true about Takotsubo cardiomyopathy except it is acute stress-induced cardiomyopathy typically seen in older women after sudden intense emotional or physical stress. True. It present with acute chest pain and pulmonary edema. True. Ventricle show global ventricular dilation with basal contraction. True. It has bad prognosis, especially when the trigger is emotional stress. No, bad prognosis is associated with physical stress, not emotional stress. Which of the following genetic mutation is most likely associated with this patient? Delayed puberty and lack of secondary sexual characteristic. He has history of cryptorchidism. Serum testosterone is low. Serum LH and FSH is elevated, and karyotype is 46XY. So it is primary, hypergonadotropic hypogonadism, probably due to SRY gene mutation. 60-year-old patient who is a known case of CLD patient complained of abdominal distension since 1 month. Arrange the following statement in correct order. So first portal hypertension will develop, then there will be splenic vasodilation, then lymph formation, then ascitic formation. So order is 1, 2, 3, 4. Option C. What It is the primary area of pathology of in acute onset Justman syndrome. There is angular gyrus. So angular gyrus is not in option. So inferior parietal lobule will be the answer. 22-year-old male with history of head trauma present with decreased libido, fatigue, and loss of body hair. His laboratory test showed low level of testosterone. CT brain reveals. This is what is the most likely diagnosis? Decreased libido, fatigue, and loss of body hair, and low level of testosterone are also there. It is hypogonadotropic hypogonadism. We can mark for review, clear response, and mark for review as there is confusion in this question. What is the most likely diagnosis? 8-year-old female with short stature has history of recurrent headache, seizure, exercise intolerance with proximal muscle weakness. ECG showed pre-excitation or incomplete heart block. Raised serum LDH is there, and excessive increase in LDH after exercise. Muscle biopsy showed red fiber. Red fiber feature of mitochondrial myopathy. So this is MELAS, mitochondrial encephalopathy with increased lactic acidosis and stroke. Which of the following is the most likely diagnosis for this patient? 45-year-old complain of paresthesia, numbness, occasional pain in anterolateral thigh, worsens with standing or walking and improve with sitting. There is normal muscle strength, knee reflexes are intact. Electrodiagnosis performed and confirm the diagnosis. EMG is not required while there is no role for surgery. Symptom often reduce naturally over the time of weeks if the patient may feel. So there is paresthesia, numbness, or occasional pain in interlateral thigh. Feature of this is not a feature of femoral neuropathy, not sciatic neuropathy, not peroneal neuropathy. Answer is myalgia paresthesia. Which of the following statement about prolactin regulation and effects of pituitary stalk section is false? You don't have to read whole of the question. Disruption of pituitary stalk can lead to prolactin hypersecretion due to dopaminergic inhibition. True. Pituitary stalk often result in hyperprolactinemia because dopamine from the hypothalamus normally inhibits prolactin secretion. True. TRH has a primary regulatory role in PRL secretion, and its elevation significantly contributes to PRL's hypersecretion. False. Dopamine has primary regulatory role over PRL secretions. Serum PRL can rise transiently after acute stress. True. A 45-year-old woman is diagnosed with NSTEMI. All of the following are true about drugs in NSTEMI except nitrates have mortality benefit. No, nitrates are just for symptomatic benefit. Ranolazine decreases recurrent ischemia and arrhythmia. True. Trimetazidine decreases short-term mortality. True. Nicorandil decreases arrhythmia and transient ischemia. True. So nitrates have no mortality benefit in NSTEMI. Which of the following is the most likely diagnosis? 30-year-old male with complaint of yellow discoloration of eye, brownish urine, and high-grade fever with chills since 3 days. He has dragging pain in the left upper quadrant, annular enlarging rash with central clearance over thigh. Blood smear shows following image of myriazoid are arranged in tetrads. So tetrads, myriazoids are in tetrads is a feature of babesia. So we will look for the answer in it. So heart tick-borne infection with concomitant babesia. Borrelia burgdorferi infection along with babesiosis infection. So this is the rash is consistent with the Lyme's disease, and the tetrads are consistent with babesiosis. So answer should be Borrelia burgdorferi along with babesiosis infection. Which of the following describe the next step in the management for the diagnosis? 45-year-old male with a history of head trauma with excessive thirst, frequent urination. Laboratory results showed urine osmolarity of 270, plasma osmolarity of 295. Water deprivation test was performed, but after 6 hours, there is no significant rise in urine osmolarity and plasma osmolarity, and sodium levels remain within the normal limit. MRI shows an absent bright spot in the posterior pituitary, suggestive of central diabetes insipidus. Plasma UVP levels are undetectable. Subsequent 40-year-old woman present with polyuria and polydipsia, her 24-hour urinary volume is 70 ml per kg and urine osmolarity is 210. After 8 hours of water deprivation, plasma osmolarity increases to 310 and urine osmolarity remains unchanged. Plasma AVP levels were and are undetectable. Which of the following statement best described in the next step in the management and diagnosis of this patient? So you must remember the flow chart for diagnosis of diabetes insipidus. For this, I'm not able to recall exactly. So either you can I will skip this question because I don't have time much to uh, spend on this question. All of the following are true about post cardiac injury syndrome, except post cardiac injury syndrome is usually pericarditis developed post injury, usually after drainage injection or after CT-based surgery. This syndrome is probably the result of hypersensitivity reaction that originates from injured myocardial tissue or pericardium. The principal symptom is the pain of acute pericarditis, which usually develops 1 to 4 weeks after cardiac injury. True. Most of the cases require aggressive treatment. Recurrences are common and may occur up to 2 years or more following the injury. True. But this usually require conservative management, not aggressive treatment. Aspirin is usually the treatment of choice. So we have completed 150 question. Now we will go for the question we have marked for review. Which of the following is not a paraneoplastic syndrome reported in carcinoma lung? Non-bacterial thrombotic endocarditis. I was confused between option A and D. So should I take the guess? I have answered 108 I have answered 108 questions. Uh, so we have to take some guesses also. We have to take some risk now. So we will mark none of the above, considering non-bacterial thrombotic endocarditis as a paraneoplastic manifestation. Then 18. So pain radiates from throat to the ear. Pain has reports no motor and sensory. So the distribution of pain is glossopharyngeal. So vagus nerve compression is unlikely. I will take a guess and mark glossopharyngeal neuralgia, considering. Uh, then question number 32. Which of the following statement regarding lipodystrophy in HIV is false? Lipodystrophy changes usually developed after 6 weeks of starting ART. This changes occur with protease inhibitor therapy. True. This changes occur with usage of time. True. So I was confused between A and D. I'll skip this question. I cannot take a guess. 58. Which of the following statement about prevalence and screening recommendation for common endocrine and metabolic disorder for adults is least accurate? Obesity defined as BMI of 30 or higher affects approximately 40% of adults, and screening includes calculating BMI and measuring waist circumference. Type 2 diabetes mellitus has a prevalence of over 10% in adults, and screening should begin at the age of 45 with fasting blood glucose above 126, indicative of the condition. This is true. Hyperlipidemia affect 20 to 25%. These are fact-based questions. I will skip this question. There is a high chance it will get negative. Which of the following acute intestinal ischemic condition early laparotomy? So like arterial thrombosis, arterial embolus, both should go for early laparotomy. I'll take a guess and will mark arterial thrombosis as an answer. 74. Which of the following statement is true about HSV treatment? Ganciclovir is as effective as acyclovir for HSV infection. Complete course of HIV acyclovir eradicates latent herpetic infection in 70%. Daily acyclovir therapy given for suppression of mucocutaneous herpes is associated with reduction of HIV RNA in the genital mucosa. It should reduce the HIV RNA, HSV RNA. Leave this question. What is the current guideline for colorectal carcinoma in a person with no history of no personal history? I was confused between option B and C. Will take a risk in this question because I'm 30% sure that flexible sigmoidoscopy is also done and colonoscopy every 10 years is also done. 103. It's a long question, which is for Vaptan therapy. I have no clue regarding this. We'll go on next. Which of the following statement is false regarding infectious mononuclear? In places with poor hygiene, EBV tends to infect children at lower age. True. CD4, CD8 becomes inverted. True. Lymphocytes in the crypts of the tonsil are the reservoirs of the EBV. B cells are reservoirs for EBV. CD21 is the receptor. 21 CD20 is the receptor for EBV. I will take a guess and will mark D. So consider the following statement: ulcerative colitis. I will skip this question. What is the likely diagnosis? With the history of head trauma, with decreased libido, fatigue, and loss of body hair. There is history of head trauma. So most likely diagnosis is hypogonadropic hypogonadism. So I have reviewed all the questions. Now I can submit the paper. I will not go to the question which I have skipped because or I have already marked because it may lead to the wrong answer also. So I'll submit the paper now. I secured 107 were correct, 7 incorrect, 36 were skipped. This was just a approach how to approach the MCQs session. This was not a teaching session.
Uh, uh, hello, Dr. Vineet. After
Hi.
1.5 hours, so I think even after being out of touch from the entire MCQ solving thing for over a year, I think you have done a splendid job in getting 107 of them correct, and with a staggering accuracy of 107 out of 114. That's like almost 94% correct questions in even after being out of touch for 1 year. There are a few questions that have come. I would like you to take up some of those questions from the people
Okay.
who were watching it live. So Dr. Tinku here is asking, uh, uh, when you started taking GTs for your NEET SS preparation, what was your first GT score and rank, and towards the end, how did it progress? And what did you learn from each of the GTs in terms of what did you pick up, and how did you go about betterment of your scores from GT to GT?
I took my first GT around 6 months before NEET SS. So then my rank was not that much good, and I can remember around 120 people gave that GT, and my rank was around 52 something. I don't remember it exactly, but it was not good. So later on, but I kept on giving the GT because I was revising one particular topic, but while giving GT I was able to revise whole of the subject. So that was the positive point. And yeah, then after then I kept on giving GT and revising the solutions of the GT. So it helped me improving my rank also after GTs.
So yeah. Sir, there is one more question that has come. Uh, it's from Dr. Sukanya. Dr. Sukanya, but she asks, "Hi, Dr. Vineet. Some NEET aspirants are saying, so it's a lot of people say a lot of things on all of Telegram and WhatsApp groups. So, बात ये है कि some NEET aspirants are saying कि you should already have read some super specialty books before appearing for NEET SS while preparing for NEET SS. Is that required, or your standard textbooks during your PG level itself that you use are sufficient?"
Personally saying that I read for INISS also. So I read the super specialty book for cardiology. So that was not much of help, but one or two questions came from Bronwald directly. So वो थोड़ा सा हेल्प किया था, पर ऐसा कुछ इम्पोर्टेंट नहीं है. हैरिसन शुड बी योर बेस.
From a NEET
हैरिसन.
SS perspective, sir, is it required?
No, no, no.
INISS के लिए तो it is understandable कि वो
It is
super
not. It
specialty.
is not required. You should not waste time on a super specialty book. You should read Harrison. You should practice MCQs. That is sufficient enough for a decent rank.
All right. So, how did you like about the overall difficulty level of this GT? What did you feel in terms of the types of questions that were included in this?
This was average. This GT was average. Some GTs are very difficult also in doctoral, but that is also important because कौन सी बॉल तुम्हें डक करनी है और कौन सी बॉल पे पुल शॉट मारना है वो चीज भी आना चाहिए
Yeah.
जैसा कमल शर्मा सर बोलते हैं तो वो चीज है.
So, I think it completely depends on the pitch also. Okay, not
Yes,
every pitch is a 283 kind of a pitch in a
yes, yes,
2020 game,
yes,
right?
yes.
So, I
On the
think most of the questions we have covered, sir. How to review grand test, and should I how okay, this is an important question. I think comes from Dr. Maddie. He's saying that how do you analyze your grand test, and do you add it to your regular notes that you prepare? Matlab, do you take notes from this and you know keep marking it somewhere, or do you maintain a log of क्या हो रहा है मेरे साथ और मेरे को कहाँ कहाँ इम्प्रूवमेंट लाना है?
जो इम्पोर्टेंट टॉपिक्स जैसे एडीपी के डी इम्पोर्टेंट टॉपिक में जो जो इम्पोर्टेंट टॉपिक है उसमें से अगर कुछ नया चीज मिलता है तो उसको ऐड करता था नोट्स में. मतलब हर एक चीज को नोट्स में ऐड करना जरूरी नहीं है. मतलब जैसे जेनेटिक्स में हो गया, रेयरली कोई जीन है वो तो तुम रिव्यू नहीं कर, मतलब सब कुछ चीजें याद नहीं हो सकती. तो वो चीज है कि जो चीज कॉमन है उसको तुम ऐड करो नोट्स में, और जो चीज रेयर है, जो चीज क्वेश्चन तुम वहां पे भी नहीं टच करोगे उसको, तो वो चीज ऐड करने की जरूरत नहीं है नोट्स में.
Yeah. I think Vinod, you can put the next question by Dr. Sukanya on screen. Dr. Sukanya has a follow-up question. Ki Harrison line by line it is not possible any which way in the next 4 months. So is only tables and diagrams of Harrison's, if I go through it, is it going to be helpful?
Yes, only tables and diagrams you should read, because line by line is not available, and basic notes you have made from doctoral videos are also should also be reviewed.
I think the quick revision part videos may be helpful again here.
Yes, yes, yes.
Yeah. So Dr. Saujanya has a question, sir. There's this last couple of questions. Just let's take it.
Sure.
Dr. Saujanya says, how should an MD Palmo candidate plan preparation for medical group examination? So, though it is probably not something directly related to you, but you may have met some people who have done this.
You should make notes from DocTutorial videos and review it, but I don't know how to what is what do you read in during MD Palmo. I'm not a right candidate to answer this question actually.
So that's a good that's a question well left, sir. Yeah. So I think we have taken most of the queries that were here in the chat. I think the students will be able to appreciate that the insights they can draw from the attempt that you have taken. Once again, from the side of Doc Tutorials, I thank you very, very much for taking out time and putting this effort. I think your juniors, people who are preparing for this exam and the upcoming exams, will benefit hugely from the way you have thought throughout the paper. So thank you so much. And I hope all of the students who are watching it, all of the aspirants who are watching it, I hope the video is helpful to you. Please drop in comments any questions you have. We'll try to make sure that it reaches Dr. Vineet if possible, and if he may answer to the questions even afterwards if you are watching it offline. Thank you so much everyone who was seeing this, and thank you Dr. Vineet again.
Thank you, Ravi.
Yeah, we can end the stream.